Hello, my name is Kathleen Nazaro. I'm an assistant professor of anesthesiology with the University of Pittsburgh School of Medicine. And today we're going to discuss the more important aspects of ENT or otorhinolaryngology anesthesia. I have no disclosures to make related to this presentation. The main topics we're going to be focusing on today will be related to airway endoscopy, microlaryngeal surgery, and laser surgery, which they all have a common denominator. It's surgery that involves an abnormal airway, and that is the basic of anesthesia for ENT surgery, how we're going to deal with abnormal airway. And there are several ways in which we can look at abnormal airway. One way would be to consider the anatomic regions, and it can be divided in three regions: the supraglottic structures, glottic structures, and subglottic structures. But also we can look at it based on the type of abnormality. And we can have a variety of congenital disorders and a variety of acquired disorders. And not uncommonly, we can have patients that can have a combination of disorders. It is paramount when we provide anesthesia for ENT surgery to have a very good understanding of airway anatomy, of the surgical procedure, and also to cooperate and communicate with the surgeon every single second. Our surgeon is our best friend, especially in this situation, because we're going to be sharing the airway, and we rely on their expertise and cooperation in order to get help with a difficult airway if the situation arises. As we saw before, the abnormal airway can come in many shapes and forms. It can be trauma or foreign body or tumor or vocal cord dysfunction of many reasons. So it's important to do a complete and full airway exam and physical exam on those patients to try to assess the extent of the abnormality, review any imaging that's available, whether it's a computer tomograph or MRI image, and also review, if available, the preoperative nasopharyngoscopy that many of those patients undergo in the ENT clinic before they present to the operating room. And as we can see on the left side of the screen, we can have a number of vocal cord disorders that have little or minimal airway impact or compromise, but we can also see very significant lesions that can severely compromise the airway. So it's very important for these patients to be assessed and severity of the compromise to be evaluated before they come to the operating room. There's two main questions that we want to have answered for ENT patients coming for a surgical procedure. Can this patient be ventilated with positive pressure and a mask? And can this patient be intubated, whether that's with direct laryngoscopy or one of the video laryngoscopes currently available? Unless the answer is an absolute yes to both of those questions, then airway should really be secured prior to induction of anesthesia. And that's actually not very different than all of our patients coming for a surgical procedure. If we have any doubts about mask ventilation or intubation, then airway should be secured before induction of anesthesia. What makes those patients different is that the extent of the airway abnormality may not be readily apparent as it is in the non-ENT patients, where the airway exam can be indicative of a difficult airway management situation. Patients who have had prior surgery or radiation therapy can be classified in two main categories. One that will be the patients that have a permanent tracheostomy, so their airway management is very straightforward because an endotracheal tube can be placed directly through the stoma. The second category that can be more difficult to deal with will be the patients that have an intact but altered airway. So the airway exam on the outside may appear normal, but there can be significant fibrosis or scar tissue, and that can significantly alter the anatomy and make those patients very difficult to intubate, in which case an awake intubation will be needed. Microlaryngoscopy is a technique that uses both a surgical laryngoscope and an operating room microscope in order to deal with vocal cord disorders. During microlaryngoscopy, our job as anesthesiologists is threefold. One is to make sure that the patient is adequately oxygenated and ventilated. The second one is to make sure that our surgical colleague can have adequate exposure in order to perform the procedure, which involves significant muscle relaxation, and also that the hemodynamic stability that is a hallmark of those procedures due to the very quickly changing levels of surgical stimulation is dealt with adequately. As far as oxygenation and ventilation is concerned, usually the preferred method of performing these procedures is with a very small diameter endotracheal tube, which will allow us to have a secure airway and deliver inhalational anesthetics if need be, and monitor end-tidal carbon dioxide. The downside of it is that even if the tube is small diameter, it can still be too big and obstruct the surgical view, in which case one of the other two techniques may be employed. One would be intermittent apnea, in which ventilation is provided to the patient in between short periods of surgery. It can be done for surgeries that are very, very quick, a few seconds or just a few minutes, with a significant risk associated with this, especially hypoventilation or inability to control the airway or the risk of aspiration for those patients. Or jet ventilation, which provides a little better way of oxygenating the patient than intermittent apnea, will provide the surgeon usually with an unobstructed view, but it also has significant risks such as air trapping, barotrauma, hypercarbia, so inadequate ventilation, and also the difficulty in respiratory gas monitoring and the requirement to use intravenous anesthetics due to inability to use inhalational anesthetics. Muscle relaxation is required in the majority of those procedures in order to obtain adequate surgical exposure, and it can be a problem because it can be needed right until the very end of the procedure, and at this point it may interfere with extubation in a patient who's otherwise is expected to go home, and the surgical procedure itself may not be very, very long. So it may be one of the very few situations, microlaryngoscopy procedure, it may be one of the very few situations in which a succinylcholine infusion may be the best option in order to provide adequate muscle relaxation that will not last a very long time. Hemodynamic stability can be a challenge in those cases, both due to the nature of the patient, but also the nature of the surgery. Patients who come for these procedures usually have a heavy history of alcohol and tobacco use with significant cardiovascular and respiratory disturbances, but also the surgical procedure itself is alternating maximal and minimal stimulation, usually within seconds of each other. So what seems to work the best is a reduced level of baseline anesthesia that's supplemented with a very short-acting drug such as propofol or remifentanil and esmolol, and a preference of intravenous anesthesia over inhalational anesthesia, which may actually be required, especially if the ventilation method does not allow us to use inhalational anesthetics. There's also certain patients in which a regional nerve block, whether a glossopharyngeal or superior laryngeal, may help provide anesthesia and decrease the hemodynamic instability. Laser surgery is usually, or many times, used in combination with microlaryngeal surgery, and it has significant surgical advantages because it allows the surgeon to operate with great precision, provides great hemostasis with minimal pain and edema for the patient, but it can have very significant side effects. whether we're talking about thermal injury or the photochemical reactions, mechanical effect, or the toxin release from the laser plume. As a general rule, the higher the wavelength, the higher will be the absorption by water, and the lower or the less will be the tissue penetration. So carbon dioxide laser, which has the highest wavelength among the commonly medically used lasers, will have very localized and very superficial effects. Eyes tend to be the most vulnerable organ to injury, both for the patient and the operating room staff, especially at the lower wavelengths used. Retina is vulnerable to wavelengths between 400 and 1400 nanometers, whereas the cornea is usually vulnerable to wavelengths greater than 1400 nanometers. And here's a graph showing the commonly used medical lasers, again with the carbon dioxide, the highest wavelength and the most localized and superficial effect. Airway fire should be always on our mind whenever lasers are being used and whenever the fire triad is present, meaning an ignition source, an oxidizer or an oxygen source, and fuel. And in this case, we have all three. We have an ignition source, the laser, the electric cautery. We have usually an oxidizer and rich atmosphere, and the fuel can be the endotracheal tube or the drapes or the patient's hair. There's a variety of laser-resistant endotracheal tubes that we try to use in order to minimize the incidence or the risk of airway fire. The older plastic tubes or the rubber tubes wrapped with protective metal foil are not the best option because they cannot be made reliably fireproof. The commercially available stainless steel or laser tubes are better from that standpoint. They do still have plastic parts, especially the cuff, that can be ignited. And in some situations, just a laser tube or a stainless steel tube without a cuff will be the safest alternative if we want to minimize the risk of airway fire. Airway fire precautions should always be observed when a laser surgery is being performed. We try to use a laser endotracheal tube, meaning a stainless steel endotracheal tube if available, or consider using a tubeless technique or not using an endotracheal tube at all if the technique is allowing you to do that. Reduce inspired oxygen as much as possible. Avoid using nitrous oxide, which is an oxidizer, and instead use air or helium to dilute the oxygen. Fill the endotracheal tube cuff with saline or dye. Place a sewed gauze around the airway. Use only water-based solvents. Limit laser exposure as much as possible. And always maintain a ready source of water or saline in order to extinguish the fire if one occurs. The American National Standards Institute has come up with an airway fire protocol, which includes stopping ventilation as soon as the airway fire is encountered, disconnecting the oxygen source right away and flood the airway with water, remove the endotracheal tube and examine the airway, mask ventilate the patient and reintubate, and then survey the extent of the injury, which may include a bronchoscopy. Monitor the patient for a number of hours after the surgery to assess the extent of the damage, and then if needed, if indicated, provide ventilatory support, antibiotics, and steroids. There is some controversy. Some of the authors actually do recommend removing the endotracheal tube as the first step in the airway fire protocol. So as opposed to stopping the oxygen and flooding the airway with water, just remove the burning endotracheal tube. That may make more sense if the endotracheal tube that's being used is a plastic tube that actually will melt and will catch on fire and melt, but probably less so if laser or a stainless steel endotracheal tube is used, in which case stopping the oxygen and disconnecting the oxygen source and flooding the airway to extinguish the fire may be the better first step. And here is another way of looking at it, the American Society of Anesthesiologists operating room fire protocol. It does include both the airway fire, but also the non-airway fire if it occurs in the operating room. And they do recommend removing the endotracheal tube and stop the flow on oxygen, remove the sponges, and extinguish the fire. In conclusion, when it comes to airway or operating room fire, no endotracheal tube is completely laser proof. Of course, the stainless steel tube is preferred over the plastic tube, but the laser beam can reflect off the tube and an airway fire can still occur even with a stainless steel tube. Surgical drapes, other flammable material can ignite at any moment, so it's important to keep that in mind. All the possible precautions should be taken all the times, and all the members of the operating room team should be aware and trained of the possible situations. In summary, when providing anesthesia for ENT surgery, we will always have to deal with an abnormal airway, which may not be readily apparent. So the airway management may be much more difficult than it appears at first glance. We're going to have to share the airway with the surgeon, which can be very helpful in certain situations when the airway management becomes difficult. Laser precautions should be observed at all times, but they should not be limited to fire hazards. Precautions can reduce the risk of airway fire, but cannot completely eliminate it. And that's why awareness and training are paramount in avoiding these dangers in the operating room.